This episode discusses topics related to suicide and mental health that some listeners may find distressing. If you or someone you know is struggling, we encourage you to seek support from a mental health professional or contact the crisis helpline. Listener discretion is advised.
We believe that collaborative conversations will lead to better outcomes in the world of mental health. Welcome to the Lift and Make Lighter podcast.
Hi, I'm Tom Telford. I'm here with Anna Lieber.
Hello.
We are the Lift and Make Lighter podcast team today. Anna, thanks for being here. So excited to spend time with you.
I'm excited to be here. Thank you.
I met Anna through a number of channels in the mental health space. You are a suicide ideologist. Did I say that right? Or a suicidologist. Okay.
Yeah.
Don't add in too much there. But I'm excited to spend time with Anna because, in my opinion, having met with several mental health professionals in Utah, when I have sat with you, your experience and wisdom and knowledge has been super impactful, especially on the topic of suicide. And so between your background in mental health and also being a leader in the mental health space, you've been on committees, you helped pioneer some associations in the state of Utah, you've been involved in legislation and shaping some other things that are going on. So I consider you an expert in the mental health space.
Well, thank you. I would say I'm becoming an expert, and a lot of that is because I surround myself with people smarter than me often.
Yeah, I don't know about that, but you definitely have a network of awesome people who we've been able to get to know more and more of. So today I wanted to dive into a tough topic.
Okay. You
know, it's a topic that's near and dear. You obviously are a trainer nationally on suicide. The word prevention is an interesting word that we're going to dive into today, you know, in terms of suicide prevention, but definitely the topic that's near and dear to a lot of mental health professionals is suicide.
Well, I think it's near and dear and also terrifying. And I think that's for most mental health professionals that I train, that I come into contact with, suicide is a terrifying thing. And my trainings and my hope is really to demystify that and make it less scary.
So we got to double click on this. You know, when it comes to fear or the scary component, is it because it's so final? Is it because the liability from a mental health perspective? Is it just, it's weighty, right? It's complex and it's weighty. So talk about that, the fear and the scary factor of one, being a mental health professional who's trying to help someone who is battling with suicide ideation, but also just because there's a human component of not wanting someone to leave the earth, right? Just as blunt as that, just staying alive.
Pain, right? The grief process is painful. It's kind of this existential fear that we all have. We're all going to die one day. It's inevitable. And the thought of losing loved ones, or even the fear of our own death, you know, is something we all grapple with. And suicide feels and is a different kind of death that is very terrifying. And I kind of spaced on your question, but I think maybe a good way to think about this fear might be how, if you're okay with it, Tom, how I became a suicidologist and going into that background, because I'll just share. So for me, when I became a mental health counselor, so I'm licensed mental health counselor, I came later in life. So I've worked in behavioral health for 25 plus years, but in my later 20s decided to go back and get my master's. And when I first started, I wanted nothing to do with suicide. I was completely terrified of it. for many reasons. One, I have a long personal history, familial history with suicidality. So suicide really runs intergenerationally in my family. I'm a suicide loss survivor, have lost many, friends, certainly many clients to suicide, and also, have kind of lived with the suicidal wish all of my life, either through loved ones who've struggled with the wish to die via suicide, or there was a period of my life where I had my own suicidal thoughts that were pretty intense. And I think that when I first started in the field, I wanted nothing to do with suicide. And part of that is that mental health professionals, and I would say healthcare professionals in general, do not get very good training when it comes to suicide, how to manage suicidal behaviors. It's very fear-based training, more of the legalities, right? As a healthcare provider, we have an ethical and legal obligation to prevent suicide. And that gets very complicated when it comes to the treatment. So when I started in the field, I realized pretty quickly that clients had suicidal thoughts, and I mismanaged them because I didn't have the training. And so I really had to kind of look. I became the clinical director of a large psychiatric hospital where the majority of clients were struggling with the suicidal wish. And I was following what I'd been taught in school. You assess, you hospitalize, you safety plan, and safety plans are amazing and they save lives. But the patients weren't getting better, and many times they were getting worse. So that's really about, I would say, 10, 15 years ago, I started a real deep dive into, okay, what's going on with the suicidal wish and how is it different? And what are we as healthcare professionals not doing that's impacting that? So that's kind of the background of how I dove in and learn from the experts. And then in my trainings, I really try and pull it all together and help healthcare providers, help loved ones, family members who have individuals, parents who have an adolescent who's struggling with suicidal thoughts. How can they better manage and support that person?
There's so much there that you shared, and I want to just ask you a question. When you say a suicide wish, why the word wish?
Wish, because I think that's what it is. It's a wish to not be alive. And I think what people often misunderstand when it comes to suicide is that people who struggle with suicidal ideation, right, or who are making plans to end their life, their goal in most cases, so there's a difference between medically assisted death, which is a wish to die, to not exist, and suicidal ideation, or the suicide wish in most cases. What we know about suicide and why people have suicidal thoughts, it's really there's many theories, but my favorite theory, and this is what I share with my clients, this is what I share with trainings I do with peer support staff or parents, is this idea of that there's these factors that create the suicidal wish. So one is intense pain, right? So emotional, physical pain. The second is hopelessness about that pain. So a good example is, we all feel this. If I had a kidney stone, it was probably the most painful experience of my life. And in that, I thought I'd rather be dead than have this pain. This pain is, we've all felt that, right? This pain is so painful, the physical pain or emotional pain after someone breaks your heart, or you lose a loved one, a loved one dies. you say, I don't know how I'm going to survive. I don't know how I'm going to live in this world if this is my reality, if this pain.
Yeah.
So we all feel that, and we all have those fleeting moments of escape, right?
Yeah.
I want to escape this feeling within myself. And then hopelessness comes into play there. So when I had my kidney stone, I knew I wanted to die because it was so painful, but I knew I could go to the emergency room, get some IV Toradol,
resources.
and that it would pass. I
Yeah.
knew it wasn't permanent. But clients who experience suicidal ideation feel that there is no way out for their pain. They feel hopeless, that it will never change. I will always feel this pain. The grief of losing a loved one, or the emotional pain from my, maybe it's a psychiatric disorder, maybe it's trauma, maybe it's, relationship problems. They often feel that that's never going to go away,
Yeah.
right? So that hopelessness really creates the ideation. What then moves it to more suicide attempts is lack of connectedness, right? So Thomas Joyner describes this as thwarted belongingness, and it's really a lack of connection to something outside of yourself. Sometimes it can be connection to self,
Yeah.
right? So it can be a hobby or something that you feel like you have to be there for. It could be family, right? So feeling connected to something in life. Might be nature, hobbies, family, friends, right? And when that lack of connectedness, right, increases, so they feel disconnected, or a burden, like my existence is causing harm to others, that is often when the suicidal intensity increases.
Yeah.
And then there's this idea of capacity or capability, right? What's the individual capacity to take one's life, right? So this is where lethal means comes into play, right? And access to lethal means, or kind of someone more fearless or has greater pain intolerance or pain tolerance, right? So the actual act. Many people have suicidal thoughts and suicidal wishes, but they don't feel that they would ever have the capacity to end their own life. And when all those kind of ingredients exist, that creates the suicidal crisis or the suicide attempt. So one way that I think about suicide is I'm always asking myself, does the individual pain, is it greater than their connectedness? Does the pain outweigh the individual's connectedness to life? And when that's the case, that's often when intervention and treatment is needed.
Yeah. How do you measure that? Because even hearing you describe all of this in my head, I'm thinking, there are people who have loving parents, they have a spouse, they have a child, so the connectedness that we're talking about, relationships, people that are around us. Can you talk a little bit more about that? Because oftentimes people would say, well, they had a family around them.
Yeah.
They were, it seemed that they were in a loving marriage or.
Well, it's perceived connectedness. Have you ever been at a party or surrounded by family and felt completely alone?
Sure.
Felt like there's not a person. I feel so isolated from everything, even though there's people around.
Yeah.
Even though cognitively, in one sense, these people care about me, but you don't feel it. You feel like they don't care.
Yeah.
So it's connectedness is an internal process, not an external.
Let's talk more about this.
Yeah.
For just a second, even go further into this, because I think that there is a sense of, we talked about this before we started recording, so I'll bring our listeners up to speed. There's a bit of a sense of, if there's enough groundswell of rock concerts to prevent suicide or whatever, those, the societal support for suicide prevention, as long as it grows big enough and loud enough and charismatic enough that all of a sudden things will go away. But we're really talking about this intense internalization of connectedness that is lacking. Yeah. So, and I go back to people like Robin Williams or others who are very charismatic, surrounded by Hollywood or fame or whatever. These are people who are very surrounded by people, but they don't feel it internally. So talk more about that.
Well, I think that's where, suicide prevention is important. It does a few things. It increases awareness about suicide. It, helps to normalize the suicidal experience. Because I think in one sense, we think of suicide as this, there's something wrong with that person, right? And suicide is just a way to cope with the pain of life, right? It's a coping strategy.
Yeah, my wife, who is a LMFT, will often say, suicide is just a coping strategy. It's not a great one because after that, there's no other coping strategies available. Yep. So it's a finality to it, but that's interesting to just hear you describe that it is a coping mechanism for, and is the objective again, stop the pain. I don't want to feel this way anymore.
Well, and this is where I think we kind of, as clinicians, often miss the mark. And I would say not only clinicians, but in general as parents, loved ones who are supporting someone who's experiencing this level of suicidal pain, right? Or the suicidal intensity, is that we think, okay, we need to save their life, right? That becomes our goal. We have to, and of course, that's my goal as a therapist who treats highly suicidal individuals. I want them to live. I want them to recover, but I want them more than just to live, right? The client's goal, and most individuals who are suicidal don't necessarily want to die. They just want their pain to end. And suicide seems like the only solution to end their pain, right? So when we could reframe it, as long as we're fighting, right? One thing we know about human relationships, right, is we have to be on the same page. So if I want, my child to follow the rules, right, and my child wants to go to not follow the rules, right, we've got to come to some common ground. There has to be some common goal. You do this and, there's negotiation there. And with suicide, we often forget that. So the suicide prevention is just, we're going to assess, right? Very important, those initial assessments, but then what? What happens after? The initial assessment and the safety plan, important, but then we have to work together to resolve the underlying pain. So I train clinicians, I say, as long as you're in conflict with your clients, and I would say the same to parents or anyone. So if your goal is to stop them from dying and their goal is to end pain, you now are operating with two different goals, and you're just going to be button heads because they want to end pain. You just say stay alive and live in pain. So I help people, I try and encourage, say, let's change the goal. Let's focus not on stopping death. Let's focus on improving life. Let's say we're going to work together to help end this pain. We're going to work together to alleviate and find different ways to manage the intense pain that you're in. Yeah. So it's really shifting our focus to say, I'm going to help you decrease your suffering.
Yeah. That's a brilliant standard to shoot for, but as you look at clinically, what is going to be important to bridge that gap between life ending for someone and becoming well, to stay alive, not just coping and being miserable, but staying alive because your loved ones don't want you to leave. There's a gap, there's a bridge that has to occur there. Societally, it feels like we're focusing on the surface level of it. Just keep them alive at all cost, and even just hearing you describe suicide as a coping mechanism, in my head, I'm going, this is a choice of behavior. So, and if I apply that as a parent, I'm thinking, well, I really want my kids to stop staring at their phone.
Yeah.
And so I'm going to take away the phone. I'm going to use some sort of measure to change their behavior. In this case, if it's just trying to control them from not dying, I haven't necessarily addressed the underlying root cause, which is, why do they stare at their phone all the time?
Yeah.
Because it is a coping mechanism. In a way, the phone is a child's reaching out to be connected to whatever else, information, friends, Snapchat, whatever it is, right? They're seeking connectedness. Is that also the case? Is suicide a reach for connectedness at the same time? So you got to go there with me, because I'm interested to know from the psychology of someone who is wanting to end their life. I know they don't want to be in pain, but what else is it that they're seeking for?
So, it really varies on the person, right? So definitely a desire to escape pain is always there. Sometimes the suicidal wish is a desire to alleviate others' pain. So if someone feels very strongly that they are a burden to their family or to other people, that they're causing harm, so the motivation may be, I'm creating harm for others, right? And sometimes it is saying, hey, I'm trying to be connected. It's a bid for connection, right? So we see that many times where people are saying, I'm suicidal, and they truly are. Any suicidal verbalization, sometimes with some clinical presentations, healthcare providers and parents and school teachers can say, oh, this is just attention-seeking behavior. And we can become I can't think of the word,
put off by it.
Put off
like
by it, annoyed by it.
A negative response, though. Like, this child's being dramatic.
Yep, being dramatic. And it can often feel that way, absolutely. But I think that these people and their level of pain simply require more attention, right? So is it attention seeking, or do they need more attention, right? And are they trying repeatedly to get attention and we aren't responding in the way that they need?
Yeah.
So they keep trying, right?
A gentleman I recently visited with was describing his child coming to him who had been cutting. And even as he described what was going on with his child, in my head, I'm thinking, this is a child who is bidding for connection. It wasn't a broken home, just a child in pain. And the child came to them showing them, I've been cutting, and so a very common, that maybe sound, shocking to some listeners, but very common in the mental health space, cutting other forms of self-harm in an attempt to feel differently.
Yes.
I'm not going to say attention seek, but they're trying to feel something different than they feel.
One of my kind of specializations really is the persistent wish to die. So individuals who usually starts early in childhood have always had suicidal thoughts. It's just existed with them. And often, that is a coping strategy. It's a way to manage pain, but they can also feel very comforting. So I will at times have clients, say, right now I just need to live in my fantasy suicide land. And so I'm just going to spend the evening, it's what I need to cope, right? I'm going to spend the evening planning my funeral and thinking about, what I might do and listening to suicide music or those things. And we talk about that, right? And really think about, okay, is this going to help you? Is thinking about suicide, is this comforting? Is this going to help you stay alive? Because their goal is not to die, it's just to end pain.
Yeah.
And suicide, or sometimes thinking about suicide, can. That very same client may say, hey, right now, thinking about suicide is harmful to me, and it may increase my chances of attempting suicide. So I need to do something else.
Yeah. So we're getting at the crux of this, that I think where societally, maybe the suicide awareness or prevention that tends to, in my head and in my own, own thinking, I try to listen to a lot of that and think in elevating the awareness, which is important. You talked about that, but the way that we elevate awareness and discuss prevention at times, it raises fear because the goal is to stop them from doing it. But you just described someone who maybe therapeutically, is working with their therapist on, let's lean into the emotion that you're feeling. Yeah. And so talk about that, just, and I'm going to use the word exposure therapy or the term exposure therapy, but just like someone who is scared of snakes, a therapist may say, let's talk about your fear of snakes and expose you to a little bit of that in order to alleviate the fear. So how does that apply?
Yeah.
Leaning into something versus talking about the fear of it.
It's what I think humans do very well, except for when it comes to suicide. Certainly healthcare providers, right? Empathy. We know that if someone's in pain, the way that they feel connected and the best alleviation for that pain is to feel understood by someone, to feel someone gets me. Excuse me, if we are going through something really hard, right, and we're in a lot of pain, we want someone, a friend, a loved one, to say, man, that's hard. That makes us feel better.
Yeah.
We feel more connected. The Ashai Project, which was a group of suicidologists that met, in Ashai, Switzerland, for many years, they did a ton of research and researched individuals and talked to them who had attempted suicide and said, both why didn't you reach out, what helped, right? And overwhelmingly, what those individuals said was, we never would have talked to someone in the depths of our suicidal despair if they would have wanted to talk us out of it, if they would have wanted to problem solve, right? Crisis management, we wouldn't have trusted that person. Which makes total sense, right? If we're in pain, we don't want someone to say, hey, we're, it'll be better. Brene Brown calls it silver lining it, right? Where the exact, and we do it so often in society, right?
Yeah.
Someone says, I'm getting a divorce. Well, at least you can get married again, right?
Yeah.
Or I had a miscarriage. At least you can have children, right? That's not helpful.
My wife, who lost her father, to cancer, 90% of the people who she ran into, after he passed away, well, he's in a better place.
Yes.
Well, really?
Yeah.
Other than here with his wife and children?
Yeah.
So you're right. I mean, there's a societal way to respond to. We don't know how, really.
Yes.
And that's what we're saying. But even hearing you describe that, I've had 4 knee surgeries, a back surgery. When people have said to me after surgery something to the effect of, well, you're better now, or you'll be better off. And it's like, it cheapens the pain that we go through, and so I can see that. I can see where people who are in significant pain wouldn't want someone to come in, pat them on the back and just be, well, just rub dirt on it. Like, you'll be fine. You'll get over it.
Yep. No, and really what it does clinically, right, is, and this you do not have to be a therapist to do this. In many ways, I think peer supports are better able to empathize with the suicidal wish than most healthcare providers, because it really is just a human connection, right?
Yeah.
Someone's in pain. You just say, you sit with them. You say, you empathize. That's really hard. Because the individual who's experiencing suicidal ideation is always ambivalent, right? Up until the moment in the suicidal crisis itself, it's very short, right? 5 to 15, maybe sometimes 30 minutes. That's it. Up until that point, the individual is always ambivalent, meaning part of them wants to live and part of them wants to die. So we need to think about what will increase the part of them that wants to live. And often it's connection. And how do they connect? By experiencing empathy, by having someone say, that's really hard. I'm here with you.
Yeah. And I felt that from you even the first time we met, and in my head I'm going, God's gift to the suicide world is you, and people like you who can sit in empathy and compassionately talk that way. Where do we get it wrong? And I think you've mentioned this before. I heard you speak about this possibly, but talk about the difference between reacting and responding, especially when you hear, or if a parent, someone listening in or a loved one brings up suicide thoughts or you're seeing behaviors. How do you respond versus react?
Yeah. So the first thing we have to do is to empathize with the suicidal wish. We have to try and understand why that person is feeling like they need to die to solve their problems, right? We have to understand it from a very human perspective, from their individual, what's going on with them. This isn't in most cases, it's not a psychiatric disorder, right? It's not, we used to think that suicidal thoughts were always related to psychiatric problems. That's not really proven to be the case. I think of it as more of a human experience, right? Like feeling intense grief or sadness, right? It's certainly one that's not very common, right? But it is not specific. It doesn't mean there's something wrong with that person. It just means they're in a tremendous amount of pain.
I think that is a shocker for so many. Even a couple women who I've met who are online, they're incredible founders of really the suicide awareness in a way, in their own parts of the country. But the thing that they discuss is their own teen boys or in their 20s who took their lives and they died by suicide, and they were shocked because there was no warning signs. There was no, this child has been depressed a long time. They were popular, athletic. I mean, they were, for all, societally, they looked like they had it all together.
Yeah.
So there wasn't a mental illness for, for a time. So that's hard, I think, for people to think through that, because we tend to think, well, they died by suicide. They must have had a history.
Yes.
There must have been a long time that they were suffering.
Well, and we like to think that there's something wrong, right? That there's some problem. And I think that's where, and we think that, right? And certainly there's some pain, right? There's something going on, but we like to, it makes sense to me why we want to ascribe that something caused this, right? And we want to assign blame, right? Is it the major depressive disorder? Is it the rejection, right? We want to assign blame, which makes sense because it's a terrifying thing and it's a very painful thing.
Yeah. And you can see where parents, I can see myself reacting and being so concerned, like what's going on? Why are you acting this way? Where did this come from? All of these kind of parent statements of reaction, when even hearing you kind of go through and describe this, it makes sense why people would get to that point in terms of the pain that they're experiencing.
Mm-hmm.
They just, like you said, they just want it to stop. And if they can't see a way out of it, this is, I don't know. What does the mind do? I mean, talk a little bit about that. What does the mind do to cope, and where does it naturally go to if it doesn't see an out?
Yeah.
Like, is it natural for the mind just to go to the extreme end of this is my way out?
Yeah. I don't think it's natural. I also don't think it's unnatural. So we all have escape fantasies, right? My escape fantasy, when I'm having a hard day, I'm going to move to Mexico and sell necklaces on the beach, right?
Yeah.
And that's always my option. I can always do that, right? I can always quit life, move to Mexico, do something else, right? I think we all have that. At least you have an escape fantasy.
Oh yeah.
Okay.
Like several of them.
Okay. Yeah.
Almost daily. Get on the
Yes.
bike and just ride until I'm
Yes.
tired. And
Just gonna.
yeah, my wife's, how much cash do I have and how far can I get, towards Mexico in the car?
Yeah.
So yeah.
Yeah, we all have this idea of if we can't tolerate this, if life becomes too unmanageable, we all have these fleeting fantasies, right? And they're things that we likely never do, but they help us cope, right? This idea of I could leave and go to Mexico, what it does is it makes me feel, okay, I have an out, right? So for individuals, from my vantage point, and certainly for me, right, when I had suicidal thoughts, same thing. It was just more extreme, right? And I think the danger, and what I love about the current suicide prevention processes, that I think it's a good start, is that this idea of safety plans and lethal means restriction, right? If I'm really considering one of my barriers to moving to Mexico and selling necklaces is I don't have enough money. I might last a few months, right? But if I had access, right? If I won the lottery, that reality or that escape may suddenly become a greater option. So lethal means I think of as the same way, is if we can remove access to lethal means, that is a huge, probably our best suicide prevention tool for suicide death. Same with safety plans. A collaborative safety plan that's updated, and it's basically an alternative coping strategy, right?
Yeah.
It's suicide is one coping strategy. Here's some others that you can use. And when individuals use them and buy into them, they're highly successful. Because a very small percentage of people with suicidal thoughts die by suicide. Right? So I think suicide prevention focuses really intensely on the individuals who attempt and die by suicide, but that is a tiny base rate. So if we look at 2023, right, over 50,000 people died by suicide in the United States. Way too many. But I think it was 12 plus million adults had serious suicidal thoughts. Right? So many people are suffering with suicidal intensity. And that's where I think we can do better at helping them there, right?
Yeah.
And not just focusing on what we ultimately have no control over. And I think that's where I call it tolerating the suicidal wish, right? Where I have to tolerate that to connect with this person and to empathize, I have to be able to tolerate that they may choose to end their own life.
That's a heavy moment, isn't it?
Mm-hmm.
I mean, and you talk about training and you travel and you're literally coaching the coaches, right? So these are men and women who around the country are sitting with people and you're training them to sit with them the right way. Is that what it takes? Increasing their tolerance to, instead of being so fearful or fear-based, that they're being more, I don't know, they're curious and can sit in that moment with people and not, I guess, put walls up and to try to flee from dealing with that. Yeah. So how does that go? How does that coaching the coaches go?
Well, I think you said it beautifully, because that's really it, right? tend to, and I was certainly trained to operate and to manage suicidal behaviors from a fear-based perspective. Elizabeth Sabar, who's a near miss survivor, and one of my colleagues and friends, she said something very interesting, and it was that she gets so frustrated with clinicians, right, and therapists and healthcare providers because they're so afraid, right? And she said, how can we think that fear can help prevent suicide when fear is what drives suicide? So it's almost like we're trying to we're trying to treat or combat suicide with the exact thing that causes it, right?
Yeah.
It's like giving an opiate addict more opiates, right?
Yeah.
It doesn't make sense.
It doesn't make sense. And yet it's so real. It's such a human reaction. What is the fear? When you say we're using fear to try to address fear, is the fear of the suicide wish person that living is worse than, or dying, is better than staying alive? I mean, what is the fear that that the person with the suicide wish has?
I think it really varies on the person, but it all comes down to this idea of hopelessness, really.
Yeah.
It's the fear that I'm going to cause pain, the fear that things will never get better, the fear that no one will ever love me, right? That's the fear. And then we're combating it with the fear, often it's very selfish fear, right?
Yeah, absolutely.
Fear of being sued, a fear of if my client dies by suicide, I'm not going to be a good therapist, a fear of losing that person, which is a real fear, right? We're going to miss them if they die. But we also have to get over ourselves a bit in order to help that person.
Yeah, I mean,
and to connect.
Yeah, I'm even hearing you describe it. And I'm going, I may be a JV therapist the rest of my career if I can't get to that where I can, forgive me, listeners, for calling it junior varsity and varsity, but it feels like you have to take it up a level. Hence the training, right?
Well, I think everyone can do this. Therapists, people, we can empathize. It's just sitting with someone, not trying to talk them out of suicide, right? Not trying to problem solve, and just saying, tell me about it. Help me understand. Being curious. You mentioned being curious, and just acknowledging, yeah, that's really hard. Because the individual who's suicidal, they have they're ambivalent, right? And what happens is when you actually just allow them the space to explore that themselves, they are often much better at coming up with reasons, right, of why they should live than we would ever be.
Do you find as a clinician that when you can engage that dialogue, do you ask questions like, have you been able to explore this at home with loved ones, with parents, is that often missing, that people don't have an environment where they can communicate openly without feeling like someone's just going to, bear hug them and say, no, just stay,
or take them to the hospital, right? I have those more coercive reactions of, you're suicidal, we're going to hospitalize you, right? And sometimes that's needed for sure. But hospitalization, I always remind my clinicians, hospitalization is not treatment. We think someone's suicidal or has a suicide attempt, they go to the hospital, okay, they're better now. No, they're just stabilized, and then the work happens afterwards. So individuals many individuals come to the hospital, right, and they need to be there because they're highly suicidal, but then they leave and they're still suicidal.
Yeah.
Right?
Yeah. It's just gotten them through,
Yeah.
That moment in time. When you think through people who are struggling with this and that intensity that they're going through, Can you describe a little bit more for listeners about the mindset that they may be in? Because, you know, as someone who has not had suicide ideation or thoughts, who, if it were my child, you know, who would, you know, come to me about this, it would be hard for me to get into the mindset of thinking there's nothing that you're seeing in life that is, you know, that's worth living for. There's not all these highs that, you know, that you could have. It's hard to believe that someone would think ending it is actually peaceful.
Yeah.
And I think that that's a scary thing.
Yeah.
But for so many people, the way that I've heard it described is that the ultimate way for them to feel peace in their life is to get rid of the stress, the environment that they're in, the relationships that they're in, the pressure of being a husband, a father, a provider, being in the military.
Yeah.
Some of my dear friends who are just they're doing incredible work trying to get military people to have connectedness in their lives because they've experienced so much trauma.
Yeah.
But in the mindset of the military person or others, I think that it's helpful for us to hear from you as a professional that the mindset is that's more peaceful being gone than it is to stay alive. Because if I stay alive, I have to still live with these pressures or feelings.
Yeah. I think it's sometimes it feels more peaceful, and I think for some people it just feels like I won't be in pain, right? But really thinking about, and there's many different theories, so we don't know, right? But what we do know is that individuals who experience high levels of suicidal thinking or behaviors have some kind of fundamental core beliefs about themselves very often. One is unlovability, that I am not lovable, right? So it's a deep-seated sense of shame. And this is often really hard, and unless someone's open, because these are often individuals, right? Like Robin Williams, great example.
Yeah.
You would have never known. He'd struggled with depression and substance abuse, but, you know, it's an internal process of I'm defective in some way, right? Another core belief is that I'm not capable of solving my own problems. So I'm not capable of resolving this pain. And then the third is often the persistent hopelessness, that things will never get better, right? So one way that I think about this, right, is if I'm a parent, if I'm a friend, right, I want to connect with that person in ways that won't reinforce these core beliefs. So example is if people feel I'm not capable of solving my problems, and every time they're suicidal or express suicidal thoughts, we take them to the hospital or we sit with them and, you know, make them promise to not do it, right? Yeah. We are actually reinforcing that they aren't capable versus sitting with them and saying, okay, what's going to help you move through this? What can you do, right? Yeah. If we're taking over.
So much of this, even hearing you describe that, I'm thinking, this is almost just parenting 101, like just try to be helpful and, you know, understand where they're coming from and try to, I don't know, it empowers the wrong word, but to a degree, help, I don't know, allow them to help you understand where they're coming from versus just trying to control it.
Yeah. Well, I think in many ways it is empower. We have to empower people to save their own life. Because in the reality is we have no control. Right? There's many things we can do. Yeah. We can, you know, decrease access to lethal means, but if someone's takes their own life, we have no control over that. And I make that very clear to my clients, right? I say, I eliminate the control. I say, you're right, I have no control if you choose to live or die, right? So
That's
I'm
the
putting it,
ultimate, like, real conversation right there.
Yeah.
Does that bring barriers down? Meaning the walls come down a little bit when they know, like, hey, she's not going to try to control me or control
Yeah.
the outcome. She's totally just leaving it in my hands.
yeah.
Is that the best way for a therapist to feel, or a clinician who may be fearful about having a client who is suicidal, to really get to that point where they're not internalizing or owning their
Yeah.
pain, they're just sitting with someone in it?
Yeah, I think so. And I think I'm also very clear, right? I have an ethical mandate as a licensed professional. If someone tells me I'm going to end my life, I'm going to shoot myself right now, Anna, I'm going to call 911, right? I make that very clear with my clients. Like, I am ethically bound to, if you tell me immediate, and I think of immediacy as in the next 12 to 24 hours, right? If my client is saying I'm having intense suicidality, but I can keep it together for 6 hours, great. That's enough time.
Yeah.
Right. So, but I'm very clear in that sense. I have a legal obligation.
Yeah.
If someone tells me they're going to end their life, I will intervene. But when we're talking more theoretically, right, I don't make false promises to my clients or try and control them and say, yeah, they can choose to end treatment, right? They can choose to end treatment and end their life. I will have no control over that. So I'm putting it back in their hands, which is where it always existed, right? I'm just naming the reality. And then I'm saying, and because my treatment goal has shifted, right? It's not to prevent death. It's to help alleviate suffering, right? And so that's what I really tell clients. I say, look, suicide can stay on the table, right? That's an option. We'll keep it on there. That's an option for you. But we could also work on alleviating some of the stress or pain. Do you want to try that?
Yeah.
And most of the time they'll say yeah, right? Because part of them doesn't want to die.
Yeah. Yeah. I mean, that makes sense, that at least to put it on the table. By doing that, by not taking it off the table immediately, does it also just put you in a position with them of, this woman gets it? She's going to sit with me here. She's not going to immediately try to move me somewhere where I'm not.
Yeah.
I think that that's such a great thing to learn from. And I don't know why I picture parents, hearing this or listening in, but my hope was that it's really a parenting tool, but it's also the central tool to this, which is, can you not react and sit in a moment that's highly uncomfortable? You're scared to death as a parent, but it is literally the recipe for doing it correctly. I heard someone recently say the worst thing that you could do as a parent for someone, or a child who comes to you who's struggling this way, and they use the term pile on. And the piling on is things like, what's going on, or these kind of, I don't know, when you put them on trial,
Yes.
now there's this feeling of shame that is piling on, the guilt that's piling on, all of those things. Do you see that happen? Just the way that someone may come to you in therapy and describe, I'm struggling with this, but my circle is piling on,
Oh, yes.
or whatever that.
Yes, 100%. And clinicians do it too. Clinicians pile on,
Yeah.
absolutely. Yeah, and I think the goal then is let's talk. So as to, again, I want to empower that individual and say, okay, what do you need from your mom? How could you tell them, right? So it's not me taking over, because that would reinforce that they aren't capable of solving that helplessness, right? So I want to empower them and say, okay, let's tell your mom what you need when you're suicidal. The other thing that most often happens, and that most of my clients say with this pile on, is they just, or this overreaction, this fear-based approach is people just stop talking about it.
They bury it.
So they won't tell anyone. They won't risk. I've had many clients who have been suicidal most of their lives, multiple suicide attempts, and disclosed to a previous clinician or psychiatrist one time, were involuntarily hospitalized, and they said, I'm never talking about it again with a healthcare provider. And they don't. So our reaction, right? If we kind of have a negative reaction to someone's disclosure of suicidal thoughts, we can have some real serious consequences. One, they don't talk about it. They keep it a secret, right? We can reinforce those suicidal beliefs, and that can actually trigger a suicide attempt or increase the suicidal thought. And, those are, it's not our fault, right? I'm not saying anyone's responsible for causing a suicidal act, but there's certainly things that we can do that are less helpful.
Yeah. Coach, put the coach hat on for a second, just in terms of, your experience clinically. A child comes to a parent, a spouse comes to a spouse, relationships, and someone comes to you and says, I'm struggling. What is the best reaction / response,
Well, the best reaction is to take a deep breath and to quit the internal panic in your mind and recognize what's going on. So they are coming to you and saying, I'm having suicidal thoughts, or I'm thinking about attempting suicide, or I attempted suicide last night. So the first thing that you have to, because the fear alarms will go off in your head. They do for me still. Like someone tells me that, I'm panic, right? That's our normal fear-based response when a lethal presents, something has lethal consequences, right? We're scared. So take a deep breath and recognize that the person is coming to you because of the part of them that wants to stay alive. I tell clinicians, if someone discloses suicidal thoughts, they want to be alive because they're talking to you about it. If they were 100% I want to be dead, they wouldn't be in treatment. They wouldn't be disclosing. So even if they never can say that, right? Even if the child is saying, no, I want to die, this is 100%, they're talking to you about it, which means they want to live.
Yeah, that's a positive sign.
Yeah, 100%. 100%. So, and then you have time, right? They're giving you time. They're saying, I'm struggling. So you become curious, you empathize, you say, what's going on? How can we lessen this pain, right?
Yeah.
And then certainly you want to assess, you want to safety plan, you want to always ask about, ask directly, have you been thinking about how you might end your life? Yeah, I've got the stockpile of pills. Is it okay if we take them away for right now, right? But first, you have to connect and you have to empathize. And I think when it comes to suicide prevention, and they are getting better, but that empathy and connection piece, we move too quick into safety planning and problem solving. And first, we have to connect and understand.
If you are not a human who is good at this, I would give, maybe I'm a D+ on, compassion or empathy. I mean, I think I tend, because of my personality, maybe I was raised, a little bit by, cowboy parents, rub dirt on it type mentality. How do we get better at that?
Mm-hmm. I think there's quite a few. It's practice, right?
Definitely.
So it's sitting with it.
Because I can see wanting to move to the plan very quickly. I mean, my kids joke all the time. Like, I'll ask them every morning, what's your plan today?
Yeah.
So I can see wanting to go to the plan.
Yes.
But I struggle with the compassion part, sitting with them that way and how to do that the right way.
I have my students, and if I'm doing or training, direct care staff or parents, I have them practice, which means you role play. You sit with someone, they're telling you something really hard, really painful, and you just sit with them. You don't try and problem solve. You don't try and comfort or make it better, because that's often what we want to do. And you just support. That's empathy. Man, that sounds really hard. Oh, that touches me here.
Mm-hmm.
That hurts. I can see how much pain you're in. And you just hold the platitudes, but here's how we could fix it, right?
Yeah.
And just sit with it. There's a really good book, if it's okay to recommend a book.
Of course. Any resources.
Stacy Friedenthal, who's a social worker and a suicidologist, has 2 books. One, Helping the Suicidal Person, I believe, and that's more for clinicians. And the second one is for families and friends and loved ones. And it's loving someone with suicidal thoughts. And I think has a lot of the components of what I've been talking about here, of this idea of connection and decreasing the fear response.
It's awesome.
Yeah.
When you think about the qualities of those who are doing this right, you've trained lots of professionals, and you live in this space. Compassion, empathy, those exist. What are the other human qualities that you see where you think, wow, they're really powerful? These are people who have a gift to sit with people this way. Are there other attributes?
Cognitive flexibility.
Wow.
I think that's required. Or sometimes thinking of the dialectic, right? It's holding 2 opposites in your mind as truth.
Paradox.
Yes. That is required to do. I would say that is required certainly to do any type of mental health treatment, but also to deal with the intensity of the suicidal wish. So as a parent, you have to be able to hold, my child knows that they love me or that I love them, and they want to leave me via suicide. Right? Both of those exist. My child wants to live, and they want to die at the same time. And that's hard.
I think that's the hardest, because I think we believe as humans that if I love them enough, if they feel me enough, if we are connected enough, that I can keep them here.
Yeah. And that's our hope. That's my hope.
Sure.
Of course. And I think it also requires a tremendous amount of self-compassion, right? For ourselves, for our, you said people that are doing this right. I don't know that anyone is. I'm certainly not. I'm doing my best.
Sure.
But I make mistakes all the time, right?
I think by, even my question of saying who's doing it right, it is in my head, I have to go to, there are people who have enough courage to allow people the agency, their ability to choose, which we talked about this offline, but I want to maybe just circle back to this as we wind down. How important is it for people to get well, to get to the point where not just staying alive, but when they get well, how much does agency and their own will and choice matter in all of it?
Well, what we know about human behavior, right, is if you try and control people, what happens? They resist, right? If you try and move someone, right, we're going to resist. Autonomy is extremely important, right? Feeling like we're in control of our own lives. And so we can't try and control, even though we really want to.
Yeah. Yeah, I mean, again, going back to that, maybe it's the wrong term, but to do it right, you have to have an incredible amount of faith in that moment. Just, I have to trust that by allowing the space and being supportive, that is going to exude the love and connectedness. Because when I try to control, I'm picturing like trying to grab my, child's shoulders and like, no, you're staying here. That doesn't reinforce connectedness.
No.
It reinforces I'm controlling you.
No. And I think really it is. My clients, many say things like, one thing that's very common is when the hopelessness is so severe, right? So if I'm working with someone, I acknowledge that they're in such pain that they almost have this mental constriction, right? So when someone's in pain or severe depression, we kind of get tunnel vision and we don't see anything else, right? We can't see the full range of options. So if I've done my job well enough, then they will, and we have connected, right? And the connection is there. Then I can often say to a loved one and say, I get that you can't see the full range of options or how your suffering could be alleviated. I can see something, right? So it becomes hope is the key ingredient. Mm-hmm. And when our clients or our children don't have that hope, we need to hold it for them. And our connection with them, they can often access it through us. I don't know if that makes any sense.
It does.
But it's really saying, my clients will say things to me like, I don't see it. I don't see how my life will be any better or why I shouldn't just end it now. But you see something and I'm going to trust that and I'll stay alive tonight.
Yeah.
Right. And that connection. And how do we connect? We connect through understanding.
You're so uniquely positioned to do this so well because I can see where people would say, like someone who, when I have knee surgery, I want to go see the knee surgeon who's done it 1,000 times.
Yep.
Because they can tell me, hey, if we do this, I'm going to get you back out running or on your bike. If I go see a professional who sits with people who have been suicidal and has helped them get well, even though I don't want to live, I can see where I can have faith and hope that that there's a path.
I don't think it's about expertise, maybe a part, or experience. I think it's about connection. It's about, do I feel like you understand me? Do you get my pain? Right? I think that's the most important thing.
Yeah. Yeah, I can see that. I can see where, a child feeling that from a parent or a loved one, where they can bridge that gap.
And then certainly working on treating, suicidality. I think one of the most common mistakes that healthcare providers or that parents make is think that the suicidal behavior is related to a diagnosis. And sometimes it is. So someone with major depression, right, or borderline personality disorder, we have treatments, right? Maybe it's an antidepressant, an SSRI, or cognitive behavioral therapy, or dialectical DBT, right, for borderline personality disorder. And those certainly help decrease suicide attempts. But unless you're specifically treating suicidality, let me rephrase that. If you're treating major depression, the depression gets better, the suicidal thoughts remain. They persist. It's something different. It's often tied to depression. Same with borderline personality disorder, right? The problems from the, personality structure improve, relationships improve, suicidality often remains. So I think one of the biggest mistakes that parents and loved ones make is saying, well, you're in treatment for depression. or you're in treatment for PTSD, your suicidality should be improving. And it often requires focused treatment. Could be from the same provider. It doesn't need to be a specialist necessarily, but you have to be addressing suicide separate.
Will that often come out in those therapy sessions about depression? Meaning they will disclose that, and then you as a clinician will need to address that separately?
Mm-hmm.
Okay.
Ideally.
Yeah.
But we aren't trained that way as clinicians. So what we're trained is, oh, you're suicidal, let's do the safety plan, right? And lethal means restriction, extremely important. And then let's continue to work on depression, because we like to avoid suicide.
Right.
Because it's hard.
Thinking if that gets better, that the suicide ideation will just go away.
Yeah. And sometimes it does, but most often not.
Yeah. Helpful to know
Yeah.
that that's additional.
Yeah.
That's something addition. What else? When you think about the public, the way that society addresses, the topic clinically, anything that way that you would love to just share or freestyle on?
Oh, I think it's about, well, maybe just an acknowledgement, right? That this is hard. Suicide is hard. And even when we do everything right? So thinking of my work, even when I do, from my training, I've done the best I can. I connected with someone. Sometimes they still end their own lives and they die. And it doesn't mean that the treatment or the interventions were not successful, that they weren't helpful. It just means that person had a moment of pain that was unbearable. So I think it's really this self-compassionate approach. My hope is that no one will die by suicide. The reality is I work with individuals who are highly suicidal. And it is likely, I've had many clients die by suicide, and it's likely that some will die again. And I think that's the pain I wish I could avoid. And many more clients choose to live. And that's the 12 million individuals in the world struggling, right? 11.550, I can't do math. The majority of them
A lot.
choose to live.
Yeah.
And I think that is a really hopeful message and a bit sobering, because sometimes people choose to die. And I think we have to be compassionate for ourselves. Clinicians take on a huge amount of shame and shame each other when that happens. So for any clinicians out there listening, be compassionate with your colleagues, your peers. It is not it's not a personal or professional failure. The treatment has often failed, but it's not personal or professional failures.
It would be so challenging, I mean, I have not faced that. I'm not a clinician, and so I've not experienced it, but I would imagine that is incredibly challenging to, one, to be in the field, and two, to be in a situation where you now have to you yourself have to cope with the fact that someone has made the choice.
And I think especially for parents and loved ones too, right? Same thing applies. You likely did everything right. And there's just a moment. The suicidal crisis is a moment in time. It is a short, impulsive decision that ultimately we don't have any control over.
Yeah. Well, I'm so grateful that you, for one, are in the industry, that you're doing what you're doing, that you have passion and compassion, for the work. So thank you for lifting and making lighter so many.
Oh.
I'm glad that you're involved so that those 12 million continue to have hope and resources.
Yeah.
Yeah.
Well, and all of us, right? I mean, suicide impacts all of us, even if we've never had suicidal thoughts yourself. We're all touched by it, right? So I think it's really just how can we approach the world? It's going to sound corny, with more hope and more love, and I think that's really it.
Yeah,
that's what we need.
Absolutely, which is why we're doing this today.
Yeah.
You know, continue to try to push the information out there. So thanks for being on.
Absolutely.
Appreciate it.
Thank you.
The Lift and Make Lighter podcast is brought to you by Levo, a mind care company, specializing in assessment, diagnosis, and when appropriate, responsible medication management. For more information, visit levomind.com.